We got the COVID vaccine.
We got the COVID vaccine.
So have I.
We have too.
Now that I'm vaccinated, I feel relieved, hopeful.
It's changed my life.
It feels like we've got our freedom back.
We can get out and go around and visit people.
I'm out of the cage now.
My dad is 94 years old, and I am just looking forward to spending a bit more time with him.
We can't wait to hug our grandkids.
I'm looking forward to going swimming.
We're looking forward to traveling.
And seeing my good friends.
To know that we're going to be able to meet our grandson, who we haven't gotten to meet yet.
It doesn't hurt, it doesn't cost you anything, but it does protect you and it protects lives of others.
I think getting the vaccine is the only way to get Ohio back to normal.
Please get the COVID vaccine.
Protect yourself,
your family, and your friends.
It's a game changer.
Don't hesitate.
Don't hesitate.
Vaccinate.
Hello, my name is Ursel McElroy, and I am the Director of the Ohio Department of Aging. It is my pleasure to join you today to discuss the very important topics of visitation, vaccines, and testing. It has now been a year since the beginning of what is arguably the largest public health emergency most of us will experience in a lifetime. COVID-19 took aim at older adults, threatening their health, their needed services, their interactions with loved ones, and their lives. Throughout, you have been called upon to be brave, flexible, and resilient, among other things, and I thank you. While we are still in the midst of the pandemic, I am encouraged that we have opportunities like today to begin restoring the critical connections we all very much need. During this hour, lines will be muted, but feel free to use the question function. We will make every effort to post helpful information, tools, and resources to address any questions you might have. Today, I am joined by experts in post-acute and long-term care medicine. It is my pleasure to introduce today's panelists, Dr. Jessica Coleman, Dr. Marla Haller, Dr. Thomas Slaner, and Dr. John Wigan. Since the release of the last Ohio Health Director's order to permit access to assisted living facilities, millions of vaccinations have been administered to residents and staff, and these vaccines have been shown to help prevent COVID-19 infection. In support of our state's continued commitment to provide vaccination to all older adults, and in recognition of the importance of safely reuniting families to combat isolation caused by the COVID-19 pandemic, and to provide opportunities for social interaction to improve the overall health and well-being of the residents, we will evolve the sixth amended director's order to limit access to Ohio's nursing homes and similar facilities with exceptions. Notably, we will begin by creating a separate visitation order for assisted living. Separating the assisted living facility and nursing home orders will allow us to focus our efforts on the unique characteristics of these different settings. Once published, it will be incumbent upon you to implement in a manner that is compliant yet exercises good clinical and safety practices. So I'll take the next several minutes to address the high points of what you can anticipate within the new order. It is still expected that each facility will evaluate all the following as part of developing a comprehensive plan to facilitate, implement, and oversee visitation. Case status and surrounding community, the case status in the facility, staffing levels, your access to adequate testing for residents and staff, personal protective equipment supplies, and the local hospital capacity. In addition, developing visitation policies consistent with the order and educating residents and visitors about the risk of the spread of COVID-19 and the appropriate safety measures to take to protect themselves will be required. Also, staying in substantial compliance with the current testing requirements for residents and staff will remain a key provision of the order. The order also contemplates that visitation can be conducted through different means based on a facility's structure and residents' needs. Yet in each circumstance, it is expected that best practices of infection prevention and control be adhered to. So these include, but will not be limited to, screening all who enter a facility for COVID-19 symptoms, logging the contact information of visitors, practicing good hand hygiene, wearing a mask, social distancing, cleaning and disinfecting high-touch surfaces, using PPE appropriately, effectively cohorting residents, and conducting testing of staff and residents. Now I'll take a moment to highlight some of the major changes. So the first highlight is requiring visitation unless there is a high risk of COVID-19 transmission. The emphasis here is on requiring. An assisted living facility shall allow indoor visitation at all times and for all residents, regardless of vaccination status, except for circumstances when visitation should be limited due to the high risk of COVID-19 transmission. Absent an adequate reason related to clinical necessity or resident safety, the order will require visitation to take place. Prior orders permitted, not required, visitation. The next highlight of the order. It will reflect a minimum visitation time versus a maximum time allotted. Currently, 30 minutes is the maximum time for a visit. But as we evolve the order, there will be increased discretion between the resident, families, and the facility about the length of the visits. Another change. Since we began visitation outdoor and indoor, we have emphasized the need to prepare a designated area. That remains. However, a designated area may now include a resident's room, provided it is a private accommodation. And although visits for residents who share a room should not be conducted in the resident's room, with married couples or those otherwise related as exceptions. In the case of extenuating circumstances, perhaps the health status of a resident prevents him or her from leaving the room, all attempts should still be made to enable visitation within that room while applying core infection prevention and control practices. Finally, allowing fully vaccinated residents to choose to have close contact with their visitor. Provided that he or she wears a well-fitting mask and performs hand hygiene before and after the visit, a resident can choose to touch their visitors. So now we can encourage the hand-holding, the hugging that so many residents and those that care for them and love them have been longing for and would benefit from. I also want to emphasize the point that assisted living facilities shall allow compassionate care visits at all times. And this is regardless of a resident's vaccination status, the county's COVID-19 positivity rate, or an outbreak. Compassionate care situations do not exclusively refer to end-of-life situations. The intent is to utilize a person-centered approach and work with residents, families, caregivers, clergy, and others to identify the need for these visits and to make them happen without delay when appropriate. I want to talk a bit about testing. As vaccination coverage continues to pick up, both inside the facilities and throughout the communities. And while there is excitement about the progress made, we must be vigilant about using the tools we have appropriately. COVID-19 testing has been and remains important in our efforts to swiftly detect cases and take action. And I'll spend the next several minutes addressing the testing requirements and what to anticipate as we evolve our state order. The director's order for the testing of the residents and staff of all residential care facilities will be updated to 1, require routine testing of all fully vaccinated staff once per week, and to require routine testing of all unvaccinated staff twice per week. And regardless of vaccination status, strategic testing of all residents will continue. And this includes, but is not limited to, testing residents with known or suspected COVID-19 exposure, testing symptomatic residents, or testing residents as determined clinically necessary. Now, this is a good place to emphasize the concept of fully vaccinated. Fully vaccinated for visitation, testing, and other purposes discussed today refers to a person who is equal to or more than 2 weeks following receipt of the second dose in a 2-dose series, or it's a person who is equal to or more than 2 weeks following receipt of 1 dose of a single-dose vaccine. This is an important point to note, as some staff and residents may be at the midpoint of a 2-dose vaccine, in which case they would not be considered fully vaccinated yet. State support will continue for these testing efforts, and while state support is optional, adhering to the testing requirements set forth in the order and related guidelines is not. Currently, 583 assisted living facilities receive some level of state support to satisfy the testing requirements. That's roughly 2/3 of the facilities, so it's important to review the options that will be available. And let's begin with option 1, alternating PCR and rapid antigen tests. With this option, the facility will receive 2 rounds of state-supported PCR and 2 rounds of antigen tests per month for vaccinated staff. They'll also receive 2 rounds of state-supported PCR and 6 rounds of antigen tests per month for unvaccinated staff. In addition, 4 rounds of state-supported antigen tests per month for residents will also be shipped in case of an outbreak. And then finally, as a reminder, the facility is responsible for confirmatory PCR tests in accordance with CDC guidelines. Let's take a look at how this will play out. At the top of the chart, we see the weekly cadence for vaccinated staff, while the bottom of the chart reflects a twice-weekly cadence for unvaccinated staff. So for weekly cadence for vaccinated staff, week 1, they would receive a PCR test, week 2, rapid antigen test, week 3, a PCR test, and then week 4, the rapid antigen test. In the case of the twice-weekly cadence for the unvaccinated staff person, week 1, they would receive a PCR test, and later in the week, a rapid antigen test. Week 2, they will receive 2 rapid antigen tests appropriately spread out. Week 3, a PCR test, and then a rapid antigen test. And then week 4, again, 2 rapid antigen tests appropriately spread out. Let's look at option 2 of state-supported testing, rapid antigen tests only. In this case, a facility would receive 4 rounds of state-supported antigen tests per month for vaccinated staff, while receiving 8 rounds of state-supported antigen tests per month for unvaccinated staff. In addition, they would receive 4 rounds of state-supported antigen tests per month for residents in case of an outbreak. And the facility will be responsible for any confirmatory PCR tests in accordance with CDC guidelines. So let's take a look at how this will play out. The top of the chart reflects a weekly cadence for vaccinated staff, while the bottom of the chart reflects a twice-weekly cadence for unvaccinated staff. So in the case of vaccinated staff, they will receive a rapid antigen test each week of the month. In the case of an unvaccinated staff person, they will receive 2 rapid antigen tests each week appropriately spread out for the entire month. Now option 3, PCR tests only. 4 rounds of state-supported PCR tests per month for vaccinated staff and unvaccinated staff will be provided to most facilities, in addition to 4 rounds of state-supported PCR tests per month for residents in case of an outbreak. However, there is the option to provide 8 rounds of state-supported PCR tests per month for unvaccinated staff for those facilities not operating under a clear certificate of waiver or who do not have access to an alternative means to test, such as utilizing point-of-care testing. So let's take a look again at how this scenario would play out. At the top of the chart, we see the weekly cadence for vaccinated staff, and the bottom of the chart reflects a twice weekly cadence for unvaccinated staff. In the case of most facilities, that would equate to 4 PCR tests, 1 each week per month for both vaccinated staff and unvaccinated staff. In the case of facilities that do not have the ability to utilize rapid antigen tests or point of care tests, perhaps those that are not operating under a CLIA certificate of waiver, they have the option to utilize 8 PCR tests to satisfy the required twice weekly cadence for unvaccinated staff. In the case of most facilities, they will supplement the 4 PCR tests with a rapid antigen test. And finally, option 4, opting out of state support. In the case of a facility that has opted out of state support, they are assuming full responsibility for supplying testing. And oftentimes that means forming a partnership with a private laboratory or using their point-of-care machines. Keep in mind, facilities do have an opportunity on a monthly basis to opt in or out of the state's testing program. Now, at this time, it is my pleasure to bring in Dr. Wigan.
Thank you, Director. So much has changed in the past 12 months. I've thought about this over the past several weeks as we've thought about where we were a year ago. And of course, a year ago, we were struggling with getting testing available for any facility, whether it's an assisted living or long-term care. And certainly now we better understand the behavior of COVID-19 in our facilities, the fact that individuals who are exposed to it and go into whether they're employees, staff, or even residents, that they could be asymptomatic and go into a facility without knowledge of really having COVID and spreading that to coworkers or to other residents. And so we have a much better idea of that behavior. And certainly we understand that the pandemic has had a significant toll on all of you, on employees in congregate settings, because you've lived through this. You're living through doing testing on a regular basis. You've seen coworkers who have had COVID. You've seen patients, residents who have passed away or had significant complications from this insidious disease. And then certainly the residents have also suffered, not only from COVID-19, but this social isolation that has been prevalent over the last 12 months. So I have a friend who's an executive director who really likened this to feeling like we've all been a turtle and we've pulled our neck into our shell and we've been kind of living in our shell for the last year. And one of the things that he said is we really need to kind of start sticking our neck out a little bit. And I thought of that, and I ended up finding this quote, which I think is spot on, that like a turtle, every man and woman must stick his or her neck out if he or she wants to go forward. So I wanted to highlight a couple cases that you may perhaps encounter or might help punctuate why it is that we've moved forward in this way. So this first case study is about an assisted living facility that has been doing testing, and they identified 2 positive employees who are resident facing. In other words, they interact with residents on a daily basis. And so they had 2 out of 120 total PCR tests that came back positive. Interestingly, both employees who were positive had received their second Pfizer vaccine through the Pharmacy Partnership Vaccination Program 3 weeks before testing positive. Neither of these employees were symptomatic, and in fact, one had a medical condition that possibly caused her to be immunocompromised. So I'd like to ask one of our panelists, Dr. Coleman, about how could this be accurate, and are these tests really false positives?
So in the case of these 2 employees, one, after we verified that they are fully vaccinated, to reiterate the director's point, meaning 2 weeks after the second dose of a 2-dose vaccine, or if they had had the Johnson & Johnson vaccine, that would be 2 weeks after the first dose. Then we have to think about how effective the vaccine itself is. So we hear a lot of this 94, 95% efficacy. Remember, that still leaves another 5% out who may not respond as well to the vaccine and not have the same coverage. When you add into that the fact that one of these employees has an immunocompromising condition, they're less likely to have the full immune response to the vaccine itself. So much less likely to have a false positive than to have employees who may not have responded to the vaccine.
Thank you, Dr. Coleman. So this is a chart that I have gone back to time and time again over the past year, and I think it really might help people understand the difference between PCR tests and rapid antigen tests, and what their utility and what their limitations are. And so if you look at an individual who is exposed to a virus at sometime between -2 and -1 weeks before this onset of symptoms. And also keep in mind that we may not have onset of symptoms. That's the challenge with this virus. So approximately a week after the exposure to the virus is when the PCR test as well as the rapid antigen test will most likely be positive. There's a quick ramp up to positivity in that first week after exposure, but you can see in the rapid antigen test, it drops off really rapidly. The PCR test stays elevated for a long period of time, and in fact can stretch out for 4 or 5 or even 6 weeks. If you remember back in the spring last year, we were still trying to clear people from what we thought were infectious, and they were having positive PCR tests, 5 or 6 weeks later, and we figured out that they weren't actually infectious. They were just releasing these broken down viruses that caused the test to come back positive. So when you're thinking about how you interpret these tests, and what's most important is that there's this regular cadence of testing, so that we know that people who were negative last week and now are positive, that is significant in that they've had an exposure and are positive from a COVID standpoint. So our second case study is a make-believe facility, Windy Meadows Assisted Living Facility, which has decided to take advantage of state-supported testing using rapid antigen tests. Nurse Nelson did not elect to be vaccinated when it was provided by his employer. And so he was tested on April 5th using the Abbott Binax Now card, and at that time it was negative. That night, Nelson decides to go over to a friend's house to watch the NCAA basketball championship game. And unbeknownst to him, he was exposed to somebody who had COVID-19. Well, he contracts that, and 2 or 3 days later, as you saw, he would start releasing virus, and he would be considered to be contagious. But in this case, he remains asymptomatic. He doesn't have any symptoms. And so on Thursday, April 8th, he's tested again because he's unvaccinated. And now the Abbott Binax Now card turns positive. Because he's asymptomatic, and the recommendation is to confirm that positivity with a PCR test that's performed, Nelson has to isolate and be off of work. And the PCR test is done, and over the course of a couple days is then found to be positive, confirming that indeed he's positive. So I guess the questions that come up from that is it necessary for unvaccinated staff to be tested twice weekly? And then also, why can't assisted living facilities maintain this once weekly testing of all employees? And so I'd like to turn to Dr. Lehner to help provide his thoughts about both of these questions.
First of all, we have to remember that our objective is to keep our residents, staff, and families safe. And we also know that as we do these gradually reopening of the facilities, there's some increased risk for exposure because we're going to have more people in the buildings and more activity in the building. We also know that more than 50% of the cases that come from the community come from asymptomatic individuals, not unlike the case that Dr. Wiegand just described. So the reason for testing, I believe that testing twice weekly is important and is necessary. As you saw in that graph that Dr. Wiegand showed, in this particular case, I should mention that we're talking about the rapid antigen testing. So back to that graph that Dr. Wiegand showed, the window of opportunity to identify a positive employee in this case is pretty narrow. So it's better and it's more efficacious to identify those positive individuals by testing twice weekly. If you test once weekly with the rapid antigen testing, the likelihood of missing that asymptomatic positive employee or person is much greater. Then the second question, why can't assisted living facilities maintain once a week testing of all employees? Recognizing that's been the cadence up to now, again, our goal is to keep people safe, keep our employees and residents safe, and to be able to continue this process of reopening our facilities. Knowing that we're going to have increased traffic in the facilities, people from the outside that may have lifestyles or may be unknowingly positive. The only way to identify those asymptomatic positive people, employees, as well as others, is to do the twice a week testing. So once again, I think that in this case, testing twice a week is opportunity for us to identify cases early and protect our residents once we've identified those patients or those employees that are shedding virus. One other point is that if people that are unvaccinated and positive theoretically can shed larger quantities of the virus unknowingly, and as such are a greater risk for spread to those other residents and staff that work with, as well as visitors that are both vaccinated and unvaccinated.
Thank you, Dr. Lehner. So I'd like to ask Dr. Marla Haller, who lives down in Jackson, Ohio, which is in Region 7, to help explain a new program that the Ohio Department of Aging has stood up, of which all of us are involved. Marla?
Good afternoon, everyone. So the little bit of background about the Regional Rapid Response Assistant Program is that, Ohio recognized that with the aging population and the congregate facilities that, with COVID-19, that we experienced a major disruption in the services and functions. And so this team was and program is put together as a pandemic response. There's a holistic approach with this program. It provides the COVID-19 support for congregate care settings, and it's clinically based and regionally organized. So you will probably see in a next slide or two how that the regions are set up. It's aligned to complement the assets that are already serving Ohio, and certainly the program is replicable, that it can be activated in a future healthcare emergency. Is comprised of regional teams, and those regional teams have components of an operational coordinator, a medical director, an infection prevention and control specialist, a PPE coordinator, an outreach support team for vaccinations or testing, a regional social worker, and we thought it was important also to include a regional chaplain or hospice specialist. So as you can see by the map, it is in collaboration with the 8 regions that was set forth with the hospital preparedness regions. And each region has its own medical team that was depicted by the list of identified individuals. And the rapid teams are listed here. As you can see, Dr. Lehner, Dr. Jessica Coleman, Dr. Todd Sobels, Dr. Cantor, Dr. McLean, Dr. Shank, myself, and Dr. Muma. And then there's also a very important clinical advisory group, and that is comprised of those listed, Dr. Mary Applegate, Dr. Canone, Dr. Francis, Alan Fox, Dr. Robin Jump, Terry Prince, Dr. Sorg, Dr. Trevino, Dr. Bruce Vanderhoff, and of course, Dr. Wigan. So we are very humbled and excited to be a part of this team, and know that we are out there to serve the state of Ohio in whatever capacity that we need to serve for not only this pandemic, but future emergencies.
Thank you, Dr. Haller. So we'd like to spend a couple minutes talking about the safe visitation program that we'd like to implement moving forward. You know, the clinical advisory group of the RAP program was asked a number of weeks ago to envision what visitation would look like, considering a number of factors that you've heard about in the news. Obviously, we know that that there are risks to COVID-19 in any congregate care setting. You know, a lot of the video that we showed at the beginning of this were all individuals who were purporting the importance of the vaccine, and certainly we know that people in hospital settings who are vaccinated are actually individuals who will most likely go out to an independent living situation and not into a congregate setting. But if they do come into a congregate setting, that's a vulnerable population that we continue to be concerned about the risks of COVID-19. The other concern is that there are the number of these variant strains, sometimes considered mutant strains, which may play a role in causing surges in the coming weeks to months. And so we need to keep those things in mind as we weigh this idea of visitation. That being the case, we also understand that there's wide variations in vaccination acceptance of not only employees, but also residents and actually visitors as well. Keeping in mind that all of us have experienced significant pandemic fatigue, and we certainly understand the adverse consequences of social isolation to those individuals that all of us care for in our facilities. Many of you have probably heard about this Swiss cheese model. And what that speaks to is a staged program where we create layers of protection, understanding that no one layer is effective in and of itself to fully protect. And in fact, there are no zero risk solutions, even when you line up a bunch of pieces of Swiss cheese as an analogy to trying to protect those people who live in our facilities. So the recommendation is going to continue to do some of the things that we do. Screening, asking questions of exposure, travel, symptoms, and then also testing temperatures at the door. I've heard a number of people say, but we never really are picking up anybody who has a fever. Well, in fact, there have been facilities that have identified people who have had COVID or potentially had COVID due to elevations of temperature. So that's our first line. And then as we move through the next stage, we would recommend that we have continued washing of hands and continued wearing of masks, but we're also going to recommend another layer, which is rapid antigen testing of visitors. It's a 15-minute test. It will require organization of that, but that's the recommendation that's come forward from the CMS. They feel that there is and we agree that if we can do a test on a visitor and demonstrate that they're positive on that rapid antigen test, then that correlates with a likelihood that that individual is infective at that time. And so we wouldn't want them to come in and potentially expose others in that situation. And that, as I mentioned, even if they were falling in that outside of that narrow window of positivity for that rapid antigen test, we're going to still ask them to wear a face mask and continue to wash their hands. And obviously, the final and most effective means for protecting against this is getting vaccinated. And so I'd like to just ask Dr. Coleman if she has any comments. She was part of that in that conversation that we had and thinking about those various layers of protection.
Thank you, Dr. Wygand. In going back to the slide that Dr. Haller showed with that large list of folks on the Clinical Advisory Committee, I think you all can appreciate how difficult it was to come to a consensus. We're all very protective of our residents, as all of you are, and we wanted to open up in a way that allowed them to decrease social isolation, to see their families, to see their grandchildren, to have a hug. But we were nervous to do it in a way that would lead to spread of COVID, that would lead to death and hospitalization. The consensus that we came to was this Swiss cheese model that Dr. Wygand shared. This is a model that allows us to minimize the spread of COVID while we maximize visitation. This is really important to consider as you start to do this in your own facilities, knowing that every decision will be a thoughtful one and one that protects your residents in both ways. Remembering that social isolation can be a very dangerous morbidity. So by going through each of these individual steps, we're taking a layer upon layer upon layer approach to wrap those that we care about and that we've been entrusted with in this protection that allows us to do both of those things simultaneously. We're at a point between last week and this of a real transition in the guidance that we're getting and developing. It's a very exciting time. Just as we're getting into spring with the opportunity to do more outdoor visits, we sort of have a time of growth and renewal. And this is an exciting time for us as providers, and even more exciting time for you as caregivers.
Thank you, Dr. Coleman. Certainly, some assisted livings fall into a category what are sometimes called shared communities. In other words, what I sometimes think of as continuous care retirement communities, or other communities that have a nursing facility interconnected by hallways or under the same roof as an assisted living facility. That's a challenge sometimes when you think about that there's a different regulatory compliance related to those different places of service. And sometimes the staff is asked to cover both the nursing facility and the assisted living facility. And the other challenge is that COVID is a non-discriminating virus. It doesn't just say, I'm going to go and infect a nursing facility, and it can spread throughout an entire facility. And so the goal of the clinical advisory group and these programs is to try to create testing guidelines that will harmonize testing across shared communities, as well as in separate assisted living and nursing facilities. The CMS guidance regarding outbreak management is going to permit continued visitation in areas that are not affected by COVID-19 in certain circumstances, and that's going to rely on staffing patterns, for instance, cross-covering on different units of individuals who have been found to be positive, as well as a facility layout, what the distance is between assisted living sections and nursing facility sections. And finally, the idea of this vaccination to visitation, we really see this as being an opportunity to reinforce and utilize the RAP teams that have been formed to help assist in the monitoring and outreach in a time of expanding visitation. We are going to continue to reassess these needs of these different layers of protection, such that if we don't have significant outbreaks, we may be able to liberalize and move back away from some of these recommendations. And certainly an expanded vaccination of the general population is only going to make this a better situation for everybody. But in the interim, there are some tried and true infection control measures that have really demonstrated success in decreasing a term that I like to use, COVIDity, across our facilities. The continued use of masks in the proper way that they were designed to be used, continuing to be wary and use hand hygiene using hand sanitizers or hand washing with appropriate technique, and then continuing cleaning and sanitization of high use areas, and when possible, the continued physical distancing.
Thank you, Dr. Wigan. Ultimately, we know that by increasing the number of residents and staff who are vaccinated, we can greatly reduce the risk of COVID-19 outbreaks, which helps protect you, the residents, and your families. It also furthers our opportunities to open up and keep open visitation for residents and families. Late February, we launched the COVID-19 Vaccine Maintenance Program for nursing homes and assisted living facilities. This program makes it possible for facilities to continue offering the vaccine to employees and residents who chose not to receive the vaccine earlier but now want it, as well as offer the vaccine to new employees and new residents coming into the facility. Currently, 90% of Ohio's nursing homes and 74% of assisted living facilities have responded to our online survey, and we continue to stress the importance of 100% participation. It is important that the remaining 10% of nursing homes and 26% of assisted living facilities complete the online program registration and share how their facility plans to provide the vaccine, either through the state program or by partnering with another entity. To date, the program has already delivered 16,000 vaccine doses with an additional 30,000 scheduled through March. I want to thank you for joining us today and thank you for all that you do each day.